Okay, it looks like we're live on Facebook and we are now live on YouTube. Good morning, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Wade Health. And today I'm joined by Kathy. Kathy, good morning.
Good morning, everyone.
Okay, so today we're talking about a condition that those in the neuropathy world know about. Neuropathy is where people typically will have weakness, or they'll have numbness, or they'll have burning pain, or they may have the feeling as though little bugs are crawling on them, tingling, things like that. CIDP is one type of peripheral neuropathy, and today we're talking about whether or not gluten can be a cause for this condition. So we're going to talk about some new research because I think it's exciting, and we're on this march for talking about autoimmune conditions. Right now, Kathy and I are talking about autoimmune neurological conditions. We've talked about autoimmune conditions to the cerebellum, the balance center. We've talked about paraneoplastic syndromes. We talked about narcolepsy recently. If you have a request, let us know. But today we're talking about CIDP. So CIDP stands for chronic inflammatory demyelinating radiculopathy. And as Kathy and I were just joking about, it sounds like super. Wait, how do you even say that? Super fragile.
For him to say it's not for me. I'm not even going to try it. It's CIDP.
Expialidocious, whatever that saying is. So we'll call it CIDP for short. So what are your thoughts, Kathy, before I keep rambling on?
Well, I did a lot of research too, and I've known several people with neuropathy, so this was really interesting to me. And again, that it's another autoimmune thing. I think we can really pull this around and let folks know, give them again another idea of what is causing this autoimmune outbreak that's driving us crazy, I think, because so many of these conditions are autoimmune. And until recently, we didn't really realize what autoimmune was, even that the body's attacking itself, trying to protect itself, for lack of a better term.
Right.
So tell me exactly what CIDP is. What's it doing?
So CIDP is under the umbrella of something that many of you may have heard of called Guillain-Barré. Guillain-Barré is an acute neurological condition where someone basically goes from being fine to then all of a sudden, pretty rapidly, they develop lots of times burning pain in their legs, horrible weakness, to the point where they're paralyzed, and then they can actually become paralyzed in their diaphragm, and it's life-threatening. Usually by that point, they're in the emergency room, they're being treated, the cause is figured out, and they are given high doses of steroids or plasma exchange or IVIG, depending on the variety of it. And usually it's an intense hospital course. These people are in the ICU for typically weeks, and then they generally have a slow recovery, but most of them make a near full recovery. Some may transition into a CIDP form, others are just basically totally fine. Now, CIDP is, so basically Guillain-Barré is referred to as an acute inflammatory demyelinating polyradiculopathy. What does that mean? If you've ever seen a nerve chart, or just think of wires that come out of your spine that coalesce to become bigger nerves, same thing in your lower back, going to your legs, those nerves have insulation around them. And the insulation can start to, basically the immune system attacks the insulation and it starts to go away. So they demyelinate like this. That's why it's called acute demyelinating polyradiculopathy. Acute inflammatory demyelinating polyradiculopathy. So that's what happens in Guillain-Barré. Now, with CIDP, with the chronic form, it tends to come on over a period of weeks where they just don't feel right and they start to get numbness and tingling. They may have some weakness, but it's usually not as bad as what I just described with Guillain-Barré. It's slower, but it tends to have a chronic course for a lot of people. So a lot of people with CIDP say they have Guillain-Barré. Technically, they're under the umbrella, but it's not really the classic Guillain-Barré. Also know under the umbrella of Guillain-Barré, it gets incredibly complicated, as do most things in healthcare these days. And there are a variety of different subcomponents of the acute form of Guillain-Barré. Can affect your eyes and cause you to have horrible balance, called Miller-Fisher. You can also, within the chronic form, have more of a motor neuropathy. You can have actually an axonal neuropathy. And that's the differentiator. Now, just because we're talking about it, and let's nerd out, new research is showing that if you were to look at a nerve, if this is a nerve, oh, this is actually a perfect example. Let's do it this way. Okay, everybody can see YouTube and Facebook. So a nerve, you would think of it as a solid wire, but the insulation around nerves kind of form like bubble wrap, but the bubble wrap is not continuous. So if you had to like put bubble wrap around a pipe and it's only 12 inches wide, like you put 12 inches of bubble wrap here, and then you put 12 inches of bubble wrap here, but there's this little space right here where there's no bubble wrap, and that's called the node of Ranvier. And so what we're finding with chronic inflammatory demyelinating radiculopathy is that we used to think it was all demyelination, and there is that, but there's a lot of inflammation. They call it paranodal. There's a lot of inflammation at the node of Ranvier. So that's the current information for everybody who's interested in CIDP. So I think that's the overview, Kathy. Maybe too in depth, but hopefully
so
it made sense.
In layman's terms, it basically attacks that covering over the nerves.
Yes.
And exposes. It takes the myelin off, so exposes the nerve. So, I mean, if any of us are thinking, even think about a nerve in your tooth, how much pain you get from that.
Right.
Take the insulation off your nerves, then they are exposed, and yeah, you're going to have all that pain. You're going to feel like bugs are calling. Something's going to be going on just because of that. So what can gangliosides, how are they involved with both those conditions? What do they do?
So it's interesting because ganglioside antibodies, oh, and Kathy, we got a comment where it sounds it's windy on your end. So I don't know if it's that or...
I did have an air conditioner on. I did turn it off. So
okay, perfect. Okay.
Hopefully that takes care of that.
So anyways, basically, what was the question again? Hit me with that one more time.
How do that ganglioside?
How do they tie in?
With both conditions?
So the ganglioside antibodies are part and parcel to the diagnosis of Guillain-Barré and particularly CIDP. So if a doctor thinks that somebody has chronic inflammatory demyelinating polyradiculopathy, they're going to know it because most peripheral neuropathy patients who quote unquote have peripheral neuropathy, think of the diabetic peripheral neuropathy. They're walking around, they're diabetic, their feet are starting to change color, and they're getting numbness and tingling, their balance may be off. But for example, like with diabetes, usually there's not horrible weakness. And most types of peripheral neuropathy, there's not horrible weakness. Not all, but most. But if a patient presents with weakness, like their feet are weak and maybe their legs are weak, but they're also having the numbness and tingling, and their exam looks like the standard neuropathy patients from their sensation standpoint, but then they're manifesting with weakness, now your doctor starts to think that CIDP may be a potentiality. Then they will probably commonly do what's referred to as a nerve conduction velocity and EMG. Most of you would know it as getting shocked and having needles poked in you. And they do that to see, are the muscles dying? How are the nerves transmitting signals? If the nerves are not sending signals quickly from point A to point B, now we really start to think there's something, quote unquote, demyelinating going on. And then they start to run blood tests. And the blood tests are for typically ganglioside antibodies. Ganglioside antibodies are seen in CIDP. Gangliosides are basically part of the cell membrane structure for nerves. They're also heavily involved in the intestines, which is why we're talking about what we're talking about today. So it's like the immune system is attacking the outer portion of the nerve, the ganglioside complex. And in fact, I read an article this morning because gangliosides are in your cerebellum. So Kathy and I talked about autoimmune cerebellar diseases a few weeks ago. And I just read this study where they said hereditary, so those who like have a hereditary cerebellar degenerative condition, as well as those who have an autoimmune degenerative cerebellar condition, like 64% have ganglioside antibodies, which is a big deal. Like, even if it's quote unquote genetic, a genetic spinocerebellar ataxia or Friedreich's ataxia or something like that, 64% of ataxia patients have ganglioside antibodies. So that's an important detail. So, you know, there's this new show out there, Kathy, you were talking about it, that I should watch it. And I can't remember what the name of the show was. There we go. And so there's a bunch of people out there with these unexplained neurological syndromes, unexplained medical syndromes that people are wondering about. If you're one of them and you have balance problems, or if you have we're describing today with the numbness and tingling and weakness, you may want to get your ganglioside antibodies checked. Now, so relative to that, and good morning to everybody who's joining, relative to ganglioside antibodies and gangliosides, well, they also see a high incidence of ganglioside antibodies in celiac disease patients. So celiac disease is where a person eats gluten, their immune system attacks the gluten molecule. The gluten molecule is a protein from wheat, barley, oats, and rye. Their immune system attacks the gluten, and then their immune system basically kills their intestines. Well, researchers have known for quite some time that celiac patients have ganglioside antibodies. Well, ganglioside is it's found in intestinal tissue as well, so that would make sense. Well, it's very interesting that now we're finding that even if you don't have celiac disease and you have a gluten sensitivity, gluten can actually bind to the ganglioside receptor complex, basically, and it can act like it stimulates antibodies to the gangliosides. So that's super fascinating. Take a step back. What does all this mean? Here's your intestines. Your intestines are two cells bound together. Basically, it's more than that. But your intestinal lining is made up of skin, for all intents and purposes, that is one cell layer thick. Each skin cell is bound together by proteins called zonulin and occludin. So the zonulin and occludin is poisoned by gluten. That's been shown in everybody. Journal Nutrients, 2015, world's foremost researcher on gluten. We've talked about it before. So now you eat gluten, intestinal lining breaks apart. Now, if you have a gluten sensitivity and there's a ganglioside problem, now that gluten molecule is binding to gangliosides, causing your immune system to attack gangliosides. Well, now you're creating antibodies to gangliosides. Well, what else has gangliosides? Nerve tissue, peripheral nerve tissue, cerebellar tissue. So that's why this is so important. And Kathy was saying she couldn't find anything about CIDP and gluten, this morning when she was researching. And I said, yeah, because I think we may be onto something. I'm not saying that egotistically, but I got into this research. I don't know how. I was just reading, and then I started seeing these associations, thinking, could it be? Could it be? And I've worked with CIDP patients, and then it's like their ganglioside antibodies go away. And I even had a case once where the neurologist was like, this can't be. There are other neurologists, this can't be. This has to be a lab error. And I said, well, we did it at your lab, at the hospital you work at, where the first test was done, and we did the second test, and they're gone. They're gone, in my opinion, because of this gluten relationship. That's my conjecture. I can't say for sure, but that's what I think was going on. So if you know somebody, I mean, even growing up, my grandma's best friend had Guillain-Barré. It's not completely uncommon. So if you know someone with CIDP, with a Guillain-Barré umbrella condition, you may want to share this information with them, because I think it's pretty important, as well as if you know somebody with a horrible balance condition that's not responding, ganglioside antibodies need to be checked. Okay, what else, Kathy? I went on a long diatribe there.
Let's see what we've got. I think we just talked about what you're asking, the connections we are seeing, that may be the connections you found. So we've done that one. How does this relate to the other videos that we've recently done?
Yeah, mainly through that the autoimmune cerebellar condition video series we did. And if
okay. So I would, just what you said a minute ago, people, if you know someone, as Dr. Gates is talking, I'm thinking about even to my husband's grandfather, who's been gone for a long, long time, but could not sleep at night. And his thing always was what Dr. Gates said, felt like bugs were crawling up and down his legs. This man was not diabetic. He probably was 5'10" and weighed 150 pounds maybe, all muscle, always a very healthy man. But he always had like an egg sandwich for breakfast. For lunch, I know he went to a fried chicken establishment, had fried chicken with all that breading, a biscuit, gravy, all these things. And I'm thinking, okay, now that I know about gluten, now I can say, okay, now I know why the poor guy was in such pain and could not sleep. And, of course, the doctor puts him on, pretty much a narcotic to knock him out so he can get some sleep. And I hated it, because I'm looking at his pill prescription thinking, Grandpa's a drug addict because he has to have it every night to sleep. Right. And as the research I read, and I know this from even my husband's mother, who had neuropathy that you worked with, the pain is just so bad when those poor folks lay down at night. And maybe you could give us a little discussion question about that. That pain. You and I discussed this, how when you lay down at night to sleep, any pain.
Right.
How that shows up. Tell us about that a little bit, because I find that very interesting.
So it's very common if there is nerve irritation that's going to manifest more at night, because that's when we're inactive. So when you're up moving around, your nervous system has a bunch of, think of like train tracks where you have the little switch thing, and you flip the switch, now the train goes down the other track. We have a bunch of switches in your spinal cord basically that shut off pain. So when you're up moving around, your muscles are moving, and when your muscles stretch, that sends all these really fast signal nerve frequencies to your spinal cord, and your joints are moving and all this stuff, and your brain is awake as we term it's aroused. Your arousal systems in your brain are firing really fast. All that works to shut off pain. And then when we lay down, now we're not active and we're starting to rest, and our neural activity in our brain is starting to go down, neurological activity. So when that happens, now you're going to be more likely to feel the pain. Also, too, when there is nerve irritation, nerves can start to swell when there's not pressure on them, like when you're walking around. So that's super, super common. And yeah, if the nerves are being irritated, that's where you're going to start to feel those symptoms. And
so that's with even just the normal everyday life. That if you have neuropathy,
it's
then
going to be
that's
way
really
worse.
Exacerbated. Yeah. And so that pain is going to just bother you all night long, and people end up on all sorts of pain medications. Where, as you just stated, you've kind of done the research. You've worked with these folks. You've kind of tied or connected the dots to see that, okay, this works. These are the symptoms we have. If we do these 2-3 different little things here, change diet, whatever, then we're seeing relief. So many of these things that when you give me the subject, what we're going to talk about, and I look them up, okay, they always say no cure, ongoing condition, whatever. We're going to give you some medications, which in this case, a lot of times is just going to be narcotics, pain medications, whatever, that you can go ahead and naturally, through diet, a few natural supplements, bring these people back to a position, we're not going to say cured, but you're going to give them a lot of relief and get them to a point where their life is a lot more manageable and a lot more livable.
I mean, that's been my experience, particularly when patients are coming in, they're evaluating us and we're evaluating them. Are they going to do what we tell them to do? Does it look like something they're going to respond to? And if it's a yes, based on our experience, and yeah, we go forward, and we've had some amazing results consistently. We just had a patient today, or not today, this week, I probably shouldn't talk about specific patients, so we'll leave that alone. But we've had some phenomenal cases that we'll be doing some new testimonials on really soon. That I'm excited to get out there. Needless to say, on your point, Kathy, in essence, as Kathy and I have been talking about for the last year plus, the American food supply has changed. We're all under more stress. We're taking more antibiotics. Whatever the factor is, we're too clean. Autoimmune disorders are exploding. So we had a question here, Kathy, from Rodney, and he said, can you expand on autoimmune cerebellar disorders, also how common it is to have multiple autoimmune disorders? So something like autoimmune cerebellar disorders, probably not super common back in the day, but now they're exploding. What are they? Well, the immune system is attacking the cerebellum for some reason. One of the most common causes is gluten, just purely gluten. It's called gluten ataxia. And we find that it's called extraintestinal manifestations of gluten are as common as the gastrointestinal, if not more common. And so most of you think, well, I have a gluten problem, I should have diarrhea. Not the case at all. The most common symptom of a gluten intolerance is actually depression, not feeling good. Other complications include things like autoimmune cerebellar disorders. The reason why, what they've shown is that the gluten molecule looks like the outer portion of your cerebellum. The outer portion of your cerebellum is made of what are referred to as Purkinje cells. Purkinje cells basically work to shut stuff off on the inner portion of the cerebellum. So gluten attaches to the Purkinje cells, or gluten antibodies do, because the Purkinje cell looks like gluten. That's basically what it is. So then your immune system attacks the cerebellum. Other autoimmune cerebellar disorders include paraneoplastic cerebellar degeneration. So that's where your immune system can be fighting a tumor or some other cancerous process long before it becomes evident, typically. And in doing so, the immune system the immune system is attacking the cancer, and it doesn't directly create immune cells that attack the cerebellum, but it like creates other gangster type immune cells that then seem to attack the cerebellum. So that is an autoimmune cerebellar condition. Within the hereditary group of cerebellar disorders, like Friedreich's ataxia, spinocerebellar ataxia, I believe there's over 30 different types. Machado-Joseph's, which is type 3, is actually one of the more common ones seen in Portuguese individuals. Basically, their cerebellum just starts to degenerate. Now, there's also within cerebellar disorders this thing called multisystems atrophy, which is a type of Parkinsonism. There's even some question if that is autoimmune. And I've worked with MSA patients, and we've had some pretty interesting successes, not saying they were cured, but their overall quality of life was improved. So in terms of autoimmune cerebellar disorders, really what you want to be thinking, Rodney, is primarily gluten. Also, how we're talking about today, how gluten may affect ganglioside antibodies, since when you take everybody with cerebellar issues, over 60% have ganglioside antibodies. Kind of interesting, something to think about for those of you who have balance problems. And then also really make sure you get a thorough workup to ensure that nothing else is going on in your body. And you have to stay tenacious, because lots of times they can take a little bit of time to figure out if there is something like a tumor growing that hasn't been found yet. So I think that answers that question. And maybe there's more that will come to me, Rodney. But then also on neuropathy, I just think it's important to highlight, if we actually haven't talked about neuropathy in a while. If this is the pie, so to speak, I always have a hard time. It goes backwards. And then I got the two videos, YouTube and Facebook. But if this is neuropathy, the neuropathy pie, the circle of the coffee mug, half of neuropathy patients, their cause is diabetes. So now we have this other half up here, the other 50%. If you take this pie, like a third of them, whatever, you guys get it. So a third of the other 50% is due to gluten. Huge finding. This was 2002, I believe. Dr. Hajivasulu from the UK is like the world's foremost neurologist, gluten guy. And he basically came out and said, okay, there's all these people with neuropathy who are told, you don't have diabetes, we don't know what's wrong with you. And so he starts researching and finds that like a third of them have antibodies to gluten, and he puts them on gluten-free diets. Their neuropathy symptoms start to improve. Important. Research came out in 2001, validated in 2008 by our neighbors here in Nevada, over in Utah, University of Utah Medical Center. They discovered that a third of quote-unquote idiopathic neuropathy patients, it's due to prediabetes. But it's not prediabetes as you'd normally find it on blood tests. You have to run this specialized type of blood test. And they found that a third of all of you walking around out there, lots of times I bring this up, Kathy, because they have pain. These are the individuals who lay down at night and have a lot of pain. Well, if you have that, you really want to think pre-diabetic or glucose intolerant, small fiber peripheral neuropathy. Now, the other piece of this pie out here include bone marrow conditions, monoclonal gammopathies of undetermined significance, as they're termed. It's where your bone marrow produces proteins that then produce antibodies that then attack your nerves, basically. And then you have a whole cluster of other autoimmune issues. Pretty much everything Kathy and I have talked about, from lupus to rheumatoid arthritis to Sjogren's, any autoimmune condition can basically be associated with neuropathy. Basically, not all of them, but most are. And vitamin deficiencies and liver problems and kidney disease. If you have COPD and you can't breathe, the lack of oxygen can cause neuropathy. So all those factors can play into it. So hopefully that summarizes it. So we're probably getting close to time, Kathy. Anything else?
The only thing I would say is that for Dr. Gates, for you folks out there, all this research he's been doing for years, he has connected the dots. So if you are one of those persons who's watching Chasing the Cure or sitting there, that's who Dr. Gates treats. That's who he sees. It's the people that can't find relief, can't get answers. He does the testing. He puts everything together. He understands the puzzle is complete when he's tested you and he sees what network he needs to follow to, there's a map that he needs to use to get you back to better health. And that's what he does. So all these answers that he gives you every week are not something he's pulling out of thin air. It's something he spent years and years studying and finding answers. And that's what he likes doing. That's what gives him joy. So if any of you are out there and have all this pain, then it might behoove you to give Dr. Gates a call, because that's a good place to start to getting back your health and to feeling and living the way you want to.
I agree 100%. And we had a question come up, well, what if they can't do that? And basically, I would say get your ganglioside antibodies checked. The hard part I struggle with this question is because this is a big issue, like relative to neuropathy. With peripheral neuropathy, so commonly people go and see their neurologist, and the neurologist is going to check you for diabetes. Maybe you get checked for prediabetes these days. They're going to check you for a B12 deficiency. They're going to check your thyroid. And they may or may not check you for anything else. The reason why I say that is that insurance companies are now dictating to neurologists what they can and cannot check. In fact, there was an article that came out a few years ago, pretty much published by two guys who had strong associations to the insurance companies. And they basically said, we went back and we looked at all these records of neurologists, and basically all the tests they're ordering are a waste of money because the treatment was not effective. Folks, this is how healthcare policy is affected in this country. So basically from that, they said neurologists shouldn't be able to order MRIs of the neck or the lower back for a neuropathy patient, and they should only be able to check them for thyroid, B12, and diabetes. To me, that's a travesty, because we work with neuropathy patients all the time, and in doing so, basically you have to lots of times run an MRI of their neck because it can look very similar to peripheral neuropathy, as an example. Point is that I'm trying to make is that you may need 8, 9, 12 pages of lab work to really figure out why your nerves are being damaged, dying, or degenerated. So all I can say is if you can't get here, find somebody who's really tenacious and trying to figure out the problem, and you may have to search for different doctors, and you're going to have to probably request that your ganglioside antibodies be checked and gluten be checked, and also know the gluten tests aren't perfect. So I don't know, but
and we are seeing that there are a lot of people that if you want the testing, you're having to pay it out of pocket.
That's basically it. Yeah,
will not cover it.
Right.
And that's like saying you're going to take a trip from New York to LA. And this is before navigation, and you've got a road map, you've got an atlas that somebody tore out, 6 of the pages.
Right.
You can't find Illinois, and you can't find Kansas, and you can't find Nevada. So
right.
see if you can get there.
Right.
That's what you're trying to do. So if you can get to Dr. Gates, it'll get you healthier faster. If you can't, I would say do away with gluten first on your own and see where that takes you. Because I have pushed that to lots of people, and I think you can find some good results on your own, even just by doing that, changing your diet, trying to clean things up. Yeah, I think
it's not expensive.
That's about all we can get.
Right. Even though people say it's expensive to be gluten-free, it's actually not. So, and then we have one last question. I think, how about you private message me, Rodney, on that, or I'll try to message you and I can give you a better opinion on that way, rather than talking about the case relative to this going on. Let's talk privately. So hope everybody has a great day, and thank you all for joining. Very interesting questions today. And yeah, we'll see you next week. Send us your feedback. Share this video, like it, whatever you're supposed to say, subscribe if you're watching on YouTube, whatever. So anyways, we'll see you all later. Thank you. Okay, ending that one, and then we got to end YouTube and stream here.